Good day, dear students. Today's lecture theme is anemias and leucoses. We will talk about red cell disorders, anemia. Anemia may be due to decreased production of erythrocytes, due to blood loss, or increased destruction of red blood cells. The second part will be about leukemias or leucoses, which may be acute and chronic. Acute and chronic leukemias may be myeloid and lymphoid. And the last part of the lecture will be about bleeding disorders. Bleeding disorders may be of three types: vascular disorders, platelet disorders, and coagulation defects. For the first, we will talk about iron deficiency anemia, the most widespread type of anemia. Iron deficiency anemia is anemia due to the deficit of iron, which is necessary for the production of hemoglobin in erythrocytes. The etiology of iron deficiency anemia includes chronic acute bleeding, usually from the gastrointestinal tract. Menstrual loss may be the cause. Decreased iron absorption after gastrectomy, upper small bowel malabsorption syndrome or Helminth's, and due to iron deficiency in food or increased growth requirements in adolescents or pregnant women. Pathogenesis. In the absence of adequate iron supply to the body or its utilization from the store, the synthesis of hemoglobin, myoglobin, and iron-containing enzymes of various cells involved in the oxidation process is upset. This impairs nutrition of tissues and accounts for the development of many symptoms of the disease. The clinical picture of iron deficiency anemia is explained by insufficient oxygen transport to tissues due to anemia on the one hand and by disordered cell respiration on the other. Symptoms and signs of iron deficiency anemia. Paleness of the skin and mucous membranes, weakness, dizziness, headache, tinnitus, spots before the eyes, fatigability, drowsiness, irritability, and even strange behavior. Breathlessness or dyspnea, tachycardia, particularly with physical exertion, arterial hypertension. Finally, heart failure or shock can result. Amenorrhea and loss of libido in women can occur. Gastrointestinal complaints, and sometimes jaundice and splenomegaly. For iron deficiency anemia, siderepenic syndrome is specific. The symptoms of this syndrome are perverted taste, pica to egg, dirt, paint, and althication changes, pleasure smelling either petrol and other substances with unpleasant odor. The next symptom is hyalosis. The synonym is angular stomatitis. It means fissura at the corners of the mouth. Atrophic glossitis means that the papilla of the tongue are leveled. The next very specific symptom of Cederer-Penick syndrome is koilonychia. Koilonychia means a spooning of the fingernails in severe cases of iron deficiency anemia. The nails become flat, sometimes spoon-like, opaque, marked by transverse folds. Rarely, Cederer-Penick dysphagia may develop, associated with a post-cricoid esophageal bag. This is the symptom of atrophic glossitis in case of iron deficiency anemia. Hyelitis, angular hyelitis, fissures in the corner of the mouth, and koilonychia, spoon-shaped nails. Laboratory tests. In case of iron deficiency anemia, hemoglobin decreases, erythrocytes also decreases. The normal values of hemoglobin and red blood cells are on the screen. In severe cases, leukocytopenia, thrombocytopenia may be. Pay attention that color index is less than 0.85. In grave disease, it may be less than 0.6 or even 0.5. This symptom is called hypochromia. The average diameter of erythrocytes is less than normal. This symptom is called microcytosis. And the number of reticulocytes is small. The blood smear in iron deficiency anemia. Microscopy of blood reveals pallid erythrocytes, hypochromia, anisocytosis, and poikilocytosis, means different size and different shape of erythrocytes. In order to confirm the iron deficiency, we should perform some laboratory tests. The iron content of the serum is decreased. Low serum ferritin concentrations always identify iron deficiency. The serum iron binding capacity of plasma is increased. Serum iron and iron binding capacity, the range of normal values, relates to the test used. In general, normal serum iron is from 13 to 27 for men and 11 to 25 millimole per liter for women. Total iron binding capacity is from 45 to 81 millimole per liter. Serum ferritin is an iron storage glycoprotein that exists as a tissue-specific isoferritin. The range of normal in most laboratories is from 30 to 300 microgram per liter. Serum ferritin concentrations closely correlate with total body iron stores. Thus, low concentrations occur only in iron deficiency. Next type of deficiency anemia is vitamin B12 folic acid deficiency anemia. This is a megaloblastic macrocytic anemia resulted from defective DNA synthesis in erythroid bone marrow precursors due to vitamin B12 folic acid deficiency. The etiology: vitamin B12 deficiency that may result from one of several factors. The first is absence of intrinsic factor secretion, gastromucoprotein. in case of atrophic gastritis, chronic gastritis type A, or after gastrectomy. The next cause may be disordered intestinal absorption in small intestine disorders. The next may be inadequate utilization in liver, kidneys, or in case of malignancy diseases. The next cause, inadequate diet in case of vegetarianism or chronic alcoholism. And the last, increased requirement in case of hyperthyroidism, pregnancy, or infancy. Pathogenesis. In conditions associated with vitamin B12 and folate deficiency, the synthesis of DNA is disordered. This in turn causes disorders in cell division. The cells become large and qualitatively inadequate. Erythroblasts are affected most severely. Large cells of embryonal hematopoiesis, megaloblasts, are found in the bone marrow instead of erythroblasts. Most megaloblasts are decomposed in the bone marrow before they reach the stage of a nucleated cell. Only a small quantity of megaloblasts is differentiated to anuclear cells, megalocytes, and enter the blood vessels. Megalocytes are larger and more saturated with hemoglobin than erythrocytes, and differ from them by morphological and functional inadequacy. Megalocytes have no such high oxygen transport capacity as the erythrocytes and are quickly decomposed. Degenerative changes in the nervous system, funicular myellosis, are referred to vitamin B12 deficiency. Degenerative changes in cerebral white matter and peripheral nerves involving axons and myelin sheaths usually precede degenerative changes in the posterior columns and corticospinal tract. The cortical nerves may also degenerate, but neural changes are minor compared with those in myelated tracts. Symptoms and signs of B12 deficiency anemia. The patient with florid cobalamin deficiency is pale with slightly icteric skin and eyes. Icteric means yellow color. Elevated bilirubin levels are related to high erythroid cell turnover in the bone marrow. Considerable weight loss is common. Various gastrointestinal manifestations may be present, including anorexia, intermittent constipation and diarrhea, and poorly localized abdominal pain. Hunter's glossitis, usually described as burning of the tongue, may be an early symptom. The mouth mucosa and posterior wall of the throat are also atrophied. The tip and edges of the tongue and also the mouth mucosa can be ulcerated. Splenomegaly and hepatomegaly may occasionally occur. This is example of Hunter's glossitis. The most typical syndrome of B12 deficiency anemia is the syndrome of funicular myellosis. Neurological involvement may be present even in the absence of anemia. This is particularly true in patients with the age more than 60 years. The neurological symptoms occasionally precede the hematologic abnormalities or occur in their absence, particularly if folic acid has been taken. In the early stages, peripheral loss of position and vibratory sensation in the extremities are accompanied by mild to moderate weakness and reflex loss. In later stages, spasticity, Babinski's responses, more severe loss of proprioceptive and vibratory sensation in the lower extremities, and ataxia emerge. Tactile pain and temperature sensations are uncommonly impaired. The upper extremities are involved later and less consistently than the lower. Some patients also may have irritability and mild depression. Paranoia, called megaloblastic madness, delirium, confusion, spastic ataxia, and at times postural hypertension may occur in advanced cases. Laboratory tests. Complete blood count is characterized by macrocytosis and hyperchromia. Color index will be more than 1.2. The smear shows macroovalocytosis, anisocytosis, and poikilocytosis. Jolly bodies, which are residual fragments of the nucleus, are very common. Unless the patient has been treated, reticulocytopenia is present. Reticulocytopenia means decreased amount of reticulocytes. Hypersegmentation of the granulocytes is one of the earliest findings. Neutropenia means decreased amount of neutrophils, develops later. Thrombocytopenia, decreased thrombocytes, is present in severe cases. The blood smear shows macroovalocytosis, anisocytosis, and poikilocytosis, jolly bodies and Cabot rings, and hypersegmentation of the granulocytes. Bone marrow shows erythroid hyperplasia and megaloblastic changes. Serum indirect bilirubin may be elevated because of ineffective erythropoiesis and shortened survival of the defective erythrocytes. Serum vitamin B12 assay is the most commonly used method for establishing vitamin B12 deficiency as the cause of megaloblastosis. Autoantibodies to gastric parietal cells can be identified in 80 to 90% of patients with anemia. More important for diagnosis are antibodies to intrinsic factor, which can be found in the sera of most patients with pernicious anemia. The next part of our lecture is leukemia or leukosis. Leukosis etiology. Exact causes of leukemia is not known, but genetic factors and environmental factors are supposed to be the causes of leukemia. Genetic factors may be chromosome abnormalities. Environmental factors, the most important, iodine, radiation, viruses. Classification of leukemia. Leukemia is divided in two main types, acute and chronic. Acute leukemia may be lymphoid and myeloid. Chronic also may be lymphoid and myeloid. Acute leukosis. The definition. Acute leukosis is usually a rapidly progressing disease characterized by replacement of normal bone marrow by blast cells of a clone arising from malignant transformation of a hematopoietic stem cell and leukemia. Pay attention that acute leukosis is connected with blast cells. Pathogenesis. The principal pathogenic defect in acute leukemia is a block in differentiation. This maturation arrest stems from acquired mutations in specific transcription factors that regulate the differentiation of immature lymphoid or myeloid progenitors. Clinical picture. Acute leukosis occurs at any age, but men and women from 20 to 30 are mostly affected. The presenting symptoms are usually non-specific, such as fatigue, fever, malaise, weight loss, and reflect the failure of normal hematopoiesis and acute septic affections. The cause of fever is often not found, although granulocytopenia may lead to an obvious and often severe bacterial infection. Pain in the throat is often one of the first complaints. Swallowing becomes painful because of necrotic ulceration of the throat and fauces. For this reason, the disease is often mistaken for necrotic tonsillitis, and only further observation of the patient and the study of the bone marrow and blood help the physician establish a correct diagnosis. This is example of necrotic tonsillitis in patient with acute leukosis. The next very important symptom, bleeding, is usually manifested by petechia, easily bruisability with mucous membrane hemorrhage or menstrual irregularity. Hematuria and gastrointestinal bleeding are uncommon. Initial central nervous system involvement, causing headaches, vomiting, and irritability, is uncommon. Bone and joint pain sometimes occur, especially in acute lymphoblastic leukosis. Inspection of the patient usually reveals grave condition from the very onset of the disease. In the terminal period, the condition is particularly grave. The patient is passive, answers the doctor's questions with difficulty, or is unconscious. On general inspection, the skin is pallid, sometimes with yellowish or grayish hue and moist. Its turgor is decreased, traces of subcutaneous and intracutaneous hemorrhages can be seen. The tourniquet and the pinch tests are positive. Hemorrhage is considerable at joints at points of injections. This is the examples of scleroma, the specific skin damage in acute myelogenous leukemia. Gum hyperplasia in case of acute leukosis, one of the symptoms of acute leukosis, and subcutaneous hematomas as a presentation of hemorrhagic syndrome in points of injections. The next symptom, necrosis and bad sores are possible. Necrosis of the mucosa, especially of the mouth and throat, especially pronounced. Ulcerous and necrotic tonsillitis, gingivitis, and stomatitis are quite characteristic of the disease. Necrotized surfaces are covered with a poorly removable gray or yellowish coat. When removed, it reveals bleeding ulcers. On general inspection, palpation reveals enlargement of separate groups of lymph nodes, spleen and liver. The heart borders are burdened, tachycardia, systolic murmur at the apex beat due to dystrophic processes in the heart muscle, and anemia are revealed. Pericarditis and exudative pleuritis are possible. Complete blood count. The blood of patients contains increased number of white blood cells. It may be 100 or even 200,000. Subleukemic forms of the disease can also occur. Leukopenia can develop in some cases at the early stage of acute leukosis. Leukopenia is then succeeded by leukocytosis. The most specific hematological sign of the disease is the presence of blast cells in peripheral blood, underlying this symptom of acute leukosis. Blast cells are usually found in the blood smear unless the leukocyte count is markedly decreased. The immature forms may amount to as high as 95 and even 99% in leukocyte formula. Only the youngest and the most mature cells can be revealed in the blood of the most patients with acute leukosis, while intermediate forms are absent. This symptom is called hiatus leukemicus. This is the next very important symptom of acute leukosis. So these two symptoms, presence of blast cells and presence of hiatus leukemicus, may help us to differ acute leukosis from other types of leukemia. Next laboratory symptom, eosinophils and basophils are absent. Other cell forms are decreased significantly. Anemia and thrombocytopenia are very common. Coagulability of blood and the bleeding time are abnormal in most cases due to thrombocytopenia. Erythrocyte sedimentation rate sharply increases. For making a diagnosis, we should use bone marrow inspiration. This picture demonstrates the procedure of bone marrow aspiration. We may use morphological study of bone marrow, flow cytometry, immunology, cytogenic analysis, and molecular marrow evaluation in order to differ the type of leukemia. Myelogram, the morphological bone marrow study. Although the diagnosis can usually be made from the blood smear, bone marrow examination should always be performed. The bone marrow puncture contains 80 or 90% of leukemic blast cells, which displace all other cell elements. All blast cells are similar morphologically, but special cytochemical reactions can be used to differentiate between them. So in case of acute leukemia, blast cells in bone marrow more than 20%, normally they should be less than 3%. Next question, chronic leukosis, and we will start from chronic lymphoid leukosis. The definition: chronic lymphoid leukosis is a clonal expansion of mature appearing lymphocytes involving lymph nodes and other lymphoid tissues with progressive infiltration of bone marrow and presence in the peripheral blood. The hematological basis in mainly B lymphocytes, morphologically mature but functionally inadequate. Chronic lymphoid leukosis is characterized by systemic hyperplasia of the lymphoid apparatus, lymphoid metaplasia of the spleen, bone marrow, and other organs. The cause of chronic lymphoid leukosis is unknown, but some cases are familial, suggesting a genetic factor. Clinical picture: chronic lymphoid leukosis usually occurs in the middle-aged and aged individuals, mostly in men. Onset is usually insidious, and chronic lymphoid leukosis is often initially diagnosed from incidental blood tests or during evaluation of asymptomatic lymphadenopathy. The initial complaints are general, such as weakness, subfebrile temperature, rapid fatigue. Initial findings include generalized lymphadenopathy and minimal to moderate hepatomegaly and splenomegaly. So for chronic leukosis are characteristic lymphoproliferative syndrome. Symptoms are progressive lymphadenopathy, splenomegaly, hepatomegaly, pain in bones, itching, and skin infiltrations. The next syndrome is characteristic intoxication. Symptoms are fever, malaise, swelling, and weight loss. The next, different types of infections, bacterial infections or viral infections, and autoimmune complications such as hemolytic anemia and thrombocytopenia. Depending on a particular enlarged lymph node group and the organ affected by lymphoid infiltration, additional symptoms may develop, such as dyspepsia, diarrhea in case of affection of the gastrointestinal tract, dyspnoea and attacks of asphyxia in compression of the trachea and bronchi by the bifurcation lymph nodes, erythema, dryness and itching of the skin in case of leukemic lymphoderma. Enlarged lymph nodes can often be reviewed during inspection of the patient. Lymph nodes of one of several groups are often enlarged. Later, all other lymph nodes become also involved. The tonsils can be enlarged too. Skin infiltration is attended by its consolidation, reddening, dryness, and scaling. At the terminal stage, the patients are extremely thin, cachexia develops. Lymphoid metaplasia of the bone marrow may cause hemorrhagic symptoms due to thrombocytopenia and anemia. leukemic infiltration can cause radicular pain and exophthalmos. A predisposition to bacterial, viral, and fungal infection occurs in late disease because of hyperglobulinemia and granulocytopenia. General inspection. On palpation, we may reveal enlarged lymph nodes and changing of their properties. The lymph nodes are elastic pasty. They don't fuse with the skin or with another lymph nodes and are painless in most cases. Even markedly enlarged, the lymph nodes never ulcerate or separate, as distinct from tuberculosis affection of the nodes. The liver and the spleen are enlarged and consolidated. Infarctions of the spleen can occur. Its palpation then becomes tender, and auscultation detects peritoneum rub friction in the left hypochondrium. This picture demonstrates lymphoproliferative syndrome, the enlargement of peripheral lymph nodes. This is anterior cervical lymph node, axillary lymph nodes, and supraclavicular lymph nodes. Enlarged lymph nodes of internal organs, paratracheal lymph nodes, which may be detected by X-ray or computer tomography, and enlarged lymph nodes of abdominal cavity, which are detected by computer tomography. Stages. The chronic lympholycosis may be staged by Binet or by Ray. Binet, ABC stages. A stage, less than 3 areas of lymphadenopathy. B stage, more than 3 areas of lymphadenopathy. And C stage, it's lymphadenopathy plus anemia and thrombocytopenia. Stages by Ray. 0 stage, lymphocytosis in peripheral blood marrow only. 1-2 stage, lymphadenopathy plus hepatosplenomegaly. 3rd-4th stage, the symptoms of previous stages plus anemia or thrombocytopenia. Classification of chronic lympholycosis by Binet is based on the number of involved regions. This is first, less than 3 regions, 2nd stage, more than 3 regions, and splenomegaly, and the 3rd stage, more than 3 regions, hepatosplenomegaly, anemia, and thrombocytopenia. How to make a diagnosis of chronic lympholycosis? We should use complete blood count. In complete blood count, we will detect leukocytosis, increased white blood cells, absolute lymphocytosis, increased amount of lymphocytes, very specific symptoms, smudge cells, which are called Gumprecht cells, will be detected in blood smear. Bone marrow study will reveal lymphocytes more than 30%. Immune phenotyping of lymphocytes will detect SD clusters. We also may use lymph node biopsy, cytogenetics, and imaging of lymph nodes, X-ray, computer tomography, or MRI. Diagnostic criteria. The first absolute lymphocytosis with more than 5,000 per liter lymphocytes with less than 55% of pro-lymphocytes. Presence of SD19, 20, 23, 24 and SD5 on B cells. And lymphocytes should dominate in bone marrow, more than 30%. This picture represents the lymphocytes with normal structure and bone marrow shadows. Gumbricht shadows or smudge shadows. This is very specific morphological symptom of chronic lympholeicosis. Underline these Botkin-Gumbricht shadows as a criteria of chronic lympholeicosis. The next type, chronic myeloid leukosis. Chronic myeloid leukosis is a clonal myeloproliferative disease caused by malignant transformation of a pluripotent stem cell and characterized by striking overproduction of granulocytes, primarily in the bone marrow, but also in extramedullary sites, for example, spleen or liver. The cause is unknown, but the effect of large dose of irradiation was demonstrated in the study of the atomic bomb survivors. Phases of chronic myeloid leukosis. 3 phases: chronic, accelerated, and blastic. Chronic lasts from 3 to 5 years. It is asymptomatic if treated. Accelerated phase lasts from 20 to 80 months. Blast appears in peripheral blood, and clone evolution is specific. Blastic phase lasts from 3 to 9 months. Blasts more than 30%, and extramedullary disease with localized immature blasts is characteristic. Nowadays, in case of treatment, appropriate treatment, the duration of these phases increased. So chronic phase may last for 25 years and more, accelerated phase from 4 to 5 years, and blastic phase from 6 to 12 months. Clinical picture. Chronic myeloid leukosis may occur in either sex and at any age, but its incidence at the age of 20-45 years is high. Patients are often asymptomatic early on. The disease may be diagnosed during an incidental complete blood count. In other patients, insidious onset of non-specific symptoms such as fatigue, weakness, anorexia, weight loss, fever, night sweats, or sense of abdominal fullness may prompt evaluation. Initially, paler bleeding and easy bruisability and lymphadenopathy are unusual, but moderate or occasionally extreme splenomegaly is common. With disease progression, splenomegaly may increase and paler and bleeding occur. Myeloid infiltration in various internal organs can be the cause of some additional symptoms, such as dyspeptic signs in affections of the gastrointestinal tract, coughing in the presence of infiltrations of the lungs and the pleura, neurological changes due to affection of the brain, the spinal cord, nerve radices. The terminal stage is characterized by pronounced cachexia and considerable enlargement of the abdomen due to markedly enlarged liver and spleen. The skin is pallid with a yellowish or grayish hue. It is flaccid and moist. The legs are affected by edema, gingivitis and necrosis of the mouth mucosa are possible. Palpation reveals moderate enlargement of lymph nodes of various groups. The liver and especially the spleen are markedly enlarged. The liver and the spleen are firm. In the presence of infarctions of the spleen, it is tender to palpation. Peritoneal friction sound can be heard over the spleen by auscultation. Applying pressure to the bones and tapping over them are painful. On this picture, hepatosplenomegaly is presented, so this is the size of liver, extremely enlarged liver, and the yellowish tint of the skin of the patient with chronic myeloid leukosis. Visible enlargement of the spleen, splenomegaly, and cachexia of the patient with chronic myeloid leukosis. Laboratory findings. Complete blood count. In the asymptomatic patients, the leukocyte count may be less than 50,000. In the symptomatic patients, the white blood cells count will increase from 200, even 600,000, extremely increased white blood cells count. The platelet count is normal or moderately increased, and the hemoglobin is usually more than 100 gram per liter. During the accelerated phase of the disease, progression, anemia and thrombocytopenia develop. Erythrocyte sedimentation rate usually increased from 30 to 70 mm per hour. On blood smears, there are all stages of granulocyte differentiation, which make 95 to 97% of all white blood elements. The absolute eosinophil and basophil concentrations can be strictly increased. Basophil-eosinophil association. This symptom is called basophil-eosinophil association, but the absolute lymphocyte and monocyte concentrations may be normal. Myelogram. The bone marrow is hypercellular on aspirate and biopsy. Cells of the myeloid series prevail, especially juvenile forms, promyelocytes, myelocytes, and myeloblasts. Characteristic also in the increase in the number of basophilic and eosinophilic promyelocytes and myelocytes. Leukocyte alkaline phosphatase is characteristically low in myeloid cells. The content of the erythroid precursors markedly decreases in the bone marrow, especially when the disease approaches its terminal stage. In the bone marrow, myelofibrosis may develop and sideroblasts may be seen in microscopy. Megakaryocyte count slightly increases in the first half of the disease. Very important for diagnosis of chronic myeloleucosis is to determine the Philadelphia chromosome. Leukemic white blood cells in chronic myeloid leukoses contain a Philadelphia chromosome, the result of a translocation between the long arms of the chromosome number 9 and 22. The resulting fusion gene produces an altered protein believed to play a key role in the development of chronic myeloid leukoses. So, diagnosis of chronic myeloid leukoses is based on clinical presentation, complete blood count, bone marrow biopsy, cytogenetics, presence of Philadelphia chromosome, and molecular genetics, detection of special fusion gene. Our third part of the lecture, clinical features of basic variants of hemorrhagic diathesis. Hemorrhagic diatheses are divided into three main types. Disorders of plasma factors of coagulation, the example is hemophilia. Disorders of platelets, the example is idiopathic thrombocytopenic purpura. And disorders of vascular hemostasis, the example is hemorrhagic vasculitis or Schönlein-Genoch purpura. For the first, we will talk about idiopathic thrombocytopenic purpura. This is a disorder that can lead to easy or excessive bruising and bleeding. The bleeding results from unusually low levels of platelets, the cells that help blood to clot. Causes. In some people, thrombocytopenia is caused by the immune system mistakenly attacking and destroying platelets. If the cause of this immune reaction is unknown, the condition is called idiopathic thrombocytopenic purpura. Idiopathic means of unknown cause. In most children with this disease, the disorder follows a viral illness such as a mumps or the flu. It may be that the infection triggers the immune system malfunction. Symptoms. Idiopathic thrombocytopenic purpura may have no symptoms, or they may include easy or excessive bruising, so-called purpura, superficial bleeding into the skin that appears as a rash of pinpoint-sized reddish-purple spots, which are called petechia, usually on the lower legs, bleeding from the gums or nose, blood in urine or stools, unusually heavy menstrual flow. Complications. Rare complications may be bleeding into the brain, which can be fatal. Laboratory features. Bleeding time is increased and more than 50-20 minutes, and thrombocyte count is decreased less than 50,000 per liter. On this slide you see superficial bleeding into the skin, which is called petechia. The skin of lower extremities is affected, purpura. The next, hemorrhagic vasculitis or Schönlein-Genoch purpura, disorder of vascular hemostasis. Schönlein-Genoch purpura is a rare inflammatory disease of the small blood vessels, capillaries, and is usually a self-limited disease. It is the most common form of childhood vascular inflammation and results in inflammatory changes in the small blood vessels. Causes. The exact cause of Schindler-Ginnov's purpura is not known, although research suggests that this disease may be caused by immune system dysfunction. For example, increased immunoglobulin A immune complexes. In some cases, it has been suggested that this disorder may be an extreme allergic reaction to certain foods such as chocolate, milk, eggs, or beans. Various drugs, bacteria, and insect bites have also been indicated as a possible cause in some cases. Symptoms usually begin suddenly. In addition to the characteristic red spotting of the skin, most often on the buttocks and backs of the legs, they may include headache, loss of appetite, and fever. The skin typically becomes red, diffuse erythema. Individuals with Schindler or purpura typically develops small red or purple spots, petechia, on the skin, especially on the legs. These purpura spots are caused by small hemorrhages under the skin and are not associated with abnormal low levels of platelets, non-thrombocytopenic, as is common with some other forms of purpura. Other skin lesions associated with Schindler-Ginov purpura include large hives, urticarial wheals, or ulcers, especially on the buttocks and legs. Swelling may occur in the face and neck due to abnormal fluid accumulation in the soft tissue of these areas, so-called angioneurotic edema. In rare cases, swelling and edema in the throat can cause breathing difficulties that can lead to life-threatening respiratory problems. Other symptoms include abdominal pain, gastrointestinal bleeding, so-called myelina, joint pain, especially the knees and ankles, immunoglobulin G nephropathy, which symptoms are hematuria or nephrotic syndrome leading to renal failure. When the central nervous system is involved, individuals with this disorder may experience severe headaches, convulsions, visual difficulties. Diagnosis. Diagnosis is based on positive capillary permeability test, so-called Konchalovsky-Rumpel-Liède pinch test. Signs of scurvy are multiple splinter hemorrhages near the distal ends of the nail, bleedings of gums, bulbar conjunctival hemorrhage, oliguria, edema of the lower extremities, arthritis. The gums become swollen, purple, spongy, and friable. They bleed readily in extreme deficiency. Secondary infection, gangrene, and losing of teeth eventually occur. Laboratory features. In vascular bleeding disorders, tests of hemostasis are usually normal. Biochemical tests detect increase of gamma globulins and C-reactive protein in hemorrhagic vasculitis. Disorders of plasma factors of coagulation, hemophilia. Hemophilia is a rare disorder in which blood does not clot normally because it lacks sufficient blood clotting proteins, clotting factors. In the most common types of hemophilia, the faulty gene is located on the X chromosome. Everyone has two chromosomes, one from each parent. A female inherits an X chromosome from her mother and X chromosome from her father. A male inherits an X chromosome from his mother and Y chromosome from his father. This means that hemophilia almost always occurs in boys and is passed from mother to son through one of the mother's genes. Most women with the defective gene are simply carriers and experience no signs or symptoms of hemophilia, but some carriers can experience bleeding symptoms if their clotting factors are moderately decreased. Symptoms of hemophilia vary depending on level of clotting factors. If clotting factor level is mildly reduced, you may bleed only after surgery or trauma. If deficiency is severe, it may be spontaneous bleeding. Signs and symptoms of spontaneous bleeding include unexplained and excessive bleeding from cuts or injuries, or after surgery or dental work, many large or deep bruises, unusual bleeding after vaccinations, pain, swelling or tightness in joints, blood in urine or stool, hematuria and melena, nosebleeds without a known cause, in infant unexplained irritability. The most important bleeding into the brain. A simple bump on the hand can cause bleeding into the brain for some people who have severe hemophilia. This rarely happens, but it's one of the most serious complications that can occur. The symptoms and signs in this case include painful prolonged headache, repeated vomiting, sleepiness or lethargy, double vision, sudden weakness or clumsiness. Complications of hemophilia may include deep internal bleeding, damage of joints, infections, and adverse reaction to clotting factor treatment. Laboratory features of hemophilia. Coagulation time is more than 50 minutes, bleeding time is normal, and decreased plasma factors 8 anti-hemophilin globulin, 9 or 11 in hemophilia. That's all.